Well, good morning, everyone. It's a privilege to have the stage today on behalf of my co-authors who are listed and pictured up on the slide. Welcome. All right, a couple of disclosures and disclaimers. I do get a stipend for being editor-in-chief. I am an advisor and external faculty and a presenter at various places. Content of this presentation is mine and mine alone. I do want to mention that part of this work was presented and conducted under an award from the Center for Medicare and Medicaid Services, Center for Innovation, and therefore this content does not necessarily reflect the views or policies of the Department of HHS, nor does mention of trade names, commercial products, or organizations imply endorsement by the U.S. government. I assume full responsibility for the accuracy and the completeness of the ideas presented. Here's the talk map. It's going to be a long one, and I'm going to try to get through it, being mindful of your time. I want to start by mentioning the first editor-in-chief of the journal, Will Shoemaker. I had the privilege of writing his memorial piece, Founding Father, First Editor, and Restless Leader. Will is an extraordinary man. He brought humility, not modesty. He was not a modest man. But Will got up every morning and said, "What am I going to learn new today?" Along with that, Will had uncompromising personal expectations. He set the bar high and always expected people to move higher. And finally, Will had deep engagement with his day-to-day work. These are three characteristics which I've tried to emulate in my own life. Let's go back to the journal and talk a little bit about the man who was president at the time, Peter Safar, when the journal was launched. Peter, of course, was the father of intensivist staffed ICUs. These pictures are from Baltimore City Hospital, where Peter said, you know, it's time to get physicians side by side with nurses. And this was now 60-odd years ago. What's remarkable is that by establishing this requirement that there should be intensivists to attend patients, Peter set the foundation for the intensivist shortage. But if we go back to the first issue of the journal, the seeds of this talk are all there. Hal Weil's presidential address. Who is likely to attend the patient in a teaching hospital when there is a massively bleeding peptic ulcer at 2 in the morning, or even at 3 in the afternoon? Our job is to change the current status by developing an operational approach which involves the experienced senior men, not in lieu of the intern, the resident, or fellow, but with him. And in so writing, Hal established the teaching-education relationship, which is the foundation of modern critical care. There were also some guidelines there talking about what training programs for physicians in critical care medicine should look like. And it's remarkable, even back in 1973, the note was physician directors and co-directors should be adequately trained in critical care medicine. They should be chosen on the basis of interest, competence, experience, and the keyword availability, rather than specialty of affiliation. Somehow we have to be there when our trainees and our patients need us. Also in that issue was a remarkable little squib. Critical care, of course, was still in its infancy, and what Dr. Shoemaker did is he went around to the leading journals and said, what's current in critical care? And in that first issue of the journal, there was a little piece on aspiration pneumonia. The key thing was that the treatment of massive aspiration pneumonia remains largely symptomatic and unsuccessful, with a mortality rate of 70%. But the authors were two men who are going to figure in this talk. At the top, Dr. John Cameron, who was a young attending in the Halstead Department of Surgery, and his chairman, George Zeidema. I need to go back in time to talk about the origins of critical care and critical care manpower to explain how we got where we are today and what we're going to do in the future. In the picture in the background, President Jimmy Carter. In the foreground, Joseph Califano, Jr. Dr. Califano was Secretary of Health, Education, and Welfare in the United States. This was the forerunner of HHS. And he asked for advice on the need and supply of physician services, all physicians in the USA. A committee, which I'm going to call Gemini, was formed. And when the report came out in 1980, they projected an overall physician surplus for the next 2 decades. many concluded that the overall increase in physicians would take care of all the staffing problems in geographics and specialties. And it so happens that was the year I graduated from medical school. Now, GEMINAC was generated under the Democratic administration. When you got to the pro-market, anti-planning mentality of the incoming Reagan administration, the government said, hands off, we're not going to worry about physician staffing. There are enough, and the market will sort it out. And in fact, these are the details of GEMINAC and its successor study, COGME. GEMINAC said by the year 2000, there would be 145,000 surplus physicians. They said, not necessary to support medical schools anymore, take the government funding away. COGME followed this with a report in 1986. The numbers were a little different, but they agreed with GEMINAC there would be mostly an excess of specialists. Well, it was worse than that. In fact, Dr. Zeidema, who had published that article in JAMA that was picked up in Volume 1 of Critical Care Medicine, had written in 1975 that Congress and lay press have concluded there are now too many surgeons and have in many instances attempted to link this to the performance of unnecessary surgery. And he, in fact, was a chairperson of one of the committees on the COGME study. This worried me a bit because having embarked on a surgical career, I was told by this man there would be too many surgeons. Around the same time, critical care was saying, excuse me, we're running a bit short. Joe Civetta, former president of this society in 1981, had written that the net result and our major problems in the 1980s is how to survive in the ICU with increased demands and decreased resources. There were not enough ICU doctors. So here was the situation, and here's how Dr. Zeidema gets into the thread. Dr. Zeidema took me on as a surgical intern and decided that I should continue as a resident. Well, that was fine, but I had to search for what kind of surgery to do. This man, Alec Heller, decided that all of the Hopkins surgery residents should take advanced trauma life support and sent all of us across town to visit with this man, R. Adams Kelly, in his shock trauma unit where the course was being taught. I went through my residency and said, this is actually pretty interesting, and I'm pretty sure people are going to have bad judgment, car crashes, and all those sorts of things. So Dr. Cameron, in due course, became chair at Hopkins, decided that Hopkins needed an attending-led trauma service, and sent me back across town to shock trauma to do a trauma fellowship. So I spent 1986, 1987 across town with Dr. Cowley and Dr. John Siegel at shock trauma, learning the arcane art and some of the science of the patients that you and I care for today. I went back to Hopkins, of course. Nice, peaceful environment, began to set up the adult trauma service, and about 6 months in, Dr. Cameron called me into the office and said, well, I need you to run the SICU. Dr. Cameron, I'm trying to launch the adult trauma service. I need you to run the SICU. There aren't many surgeons who want to do critical care. I need you to run the SICU. Okay, I got it. But I need a co-director from anesthesiology. Why? There just aren't that many surgeons who want to learn critical care. Anesthesiologists either. Maybe we can train them together. I had the good fortune to meet Dr. Mike Breslow. Mike is a member of this society, recently retired from critical care. And Mike and I, over the next 7 years or so, had the good fortune to find some very interesting, talented, and energetic young fellows. Perhaps you know 3 of them. Past President Pam Lipset, past President Cliff Deutschman, immediate past President Todd Dorman. It was a remarkable group of individuals. I'm not going to dwell on them, but I do here want to mention one other individual who we trained, and that's a man named Dr. Brian Rosenfeld. Dr. Breslow and Dr. Rosenfeld will make an appearance in a little while. At the time, it was pretty primitive. We were very fortunate to have engaged learners facilitating critical care. You see the paper charts we're holding running around with the side table, the glass bottles in the foreground, x-rays on the light board in the back. It was pretty primitive, but somehow we managed to deliver pretty good care. But the conventional wisdom of the time said, you know, you shouldn't focus too much on critical care. Managed care says there were too many physicians, and in fact, because care was made so effectively preventative, this is what the hospital parking lot was going to look like. A couple of patients over there on the right, and the back, the single doctor who would be staffing the hospital. That was the prediction that many of us were being handed in the last decade of the last century. There are other things going on in the last decade of the last century as well. It was the decade of managed care, but it was also the decade where we began to recognize the quality crisis. On the left, the cover of the famous report from the Institute of Medicine, to Error is Human. And errors were part of the fabric. They still are part of the fabric, but they were a much bigger part back in that decade. And big business got together and said, you know, we're not going to pay for errors anymore. We actually are going to hold those who provide clinical care to quality. So early in 1998, a number of large U.S. healthcare purchasers formed this group, the Leapfrog Group, to initiate breakthroughs in safety and the overall value of healthcare to consumers in the United States. They called for universal adoption of three things. The first one was, you got to have a computer to put the orders in. No more verbal orders in paper. The doctor had to put it in right where it was going to get picked up. Made sense. Second, evidence-based hospital referral. You know, it matters whether you are in a high-volume center or a low-volume center. And that high-volume center should be reporting its statistics and allowing the consumer to make a choice. All that common sense. But there was a third item in the Leapfrog list. Had to be doctors in the ICU. Where did that come from? It came from another one of our residents in the Hopkins SICU, Peter Pronovost. And one of the early things that Peter did, Peter, of course, later went on to win a MacArthur Genius Award, he said, you know, we're going to go through page by page, hospital by hospital, the literature and the available data on the relationship between having doctors in the ICU and quality. And he found that high-intensity staffing, that's ICUs where intensivists manage to co-manage all the patients, or some or none. If you look at the high intensity versus low intensity, high intensity was associated with a 30% reduction, a 1/3 reduction in hospital mortality, and a 40% reduction in ICU mortality. Well, of course, this got published, and Peter and Derek Angus and Todd Dorman ended up writing this note to JAMA in 2002. And here's the key statement. We found that greater use of intensivists in the ICU led to those significant reductions in ICU and hospital mortality and length of stay, and it didn't matter where you looked. The findings were consistent across a variety of populations and hospital settings and have potentially important implications for patient care. Well, this was a pretty big deal. The problem is there weren't enough intensivists. A couple of years before, the Quad Societies, led by the Society of Critical Care Medicine, because of the controversy surrounding physician workforce projections, critical care physicians were having a great deal of difficulty with the huge apparent demand, but the statement there were too many physicians. They found it difficult to plan for the future of their training programs. So the major professional societies commissioned a study. And since considerable technical support was required, the Compact study engaged a group called ABT Associates, a major consulting firm. This is what came out of the ABT study, reported out as the Compacts report, the Committee on Manpower for pulmonary and critical care societies. The lead author was our own Derek Angus. And this was the key figure. In blue, the projected rate of rising demand by the aging and complexity of the U.S. population. In gold, the supply of critical care physicians. The blue arrow is where we are today in 2017. People took note of this and said, oh, we have a problem. The first question was, did they actually do the study right? Congress got into the act. The U.S. Congress directed HRSA to do its own study to say, can this be true? And the answer is, yeah, it was true. Now, the numbers changed around a little bit, but that blue arrow is where we are again. There is a shortfall between effective supply and even the most optimal utilization. Well, we have a problem. This led to an acknowledgement, at least by the critical care community, that there was a critical care crisis in the United States. Mark Kelly authored this report, Framing Options for Critical Care in the U.S. And buried in that report is the following paragraph. Continuous remote intensivist staffing with video conferencing and computer-based data transmission may reduce ICU and hospital mortality rates, ICU complications, ICU and hospital length of stay, and costs. A few years later, Amber Barnato got together a group of 37 stakeholder groups, and in a two-day conference that was actually convened in September 2005, the Promise Conference, they came to a large number of conclusions, but I want to read you one paragraph. There was broad agreement on some relatively controversial topics: the need to regionalize and tier the adult critical care system, and in concert to acknowledge that some critical care services will be provided by non-critical care boarded physicians. Could be hospitalists, could be emergency physicians, and in some cases, physician extenders. So for the balance of this talk, I'm going to talk about two innovations and ultimately merging them. One, advanced practice providers, extenders, mid-levels, or as we prefer to call them, affiliate providers. And second, this notion of remote critical care, also known as tele-ICU, EICU, and so on. Now, the PANP concepts were not new. The curriculum and concepts evolved in the 1950s. The roles were developed in the 60s. And I'm going to tell you about the two founding programs. The PA program evolved through the efforts of these two individuals, Eugene Stead and Thelma Ingalls. This was down at Duke. Dr. Stead initially attempted to create a physician extender concept within the framework of nursing. That didn't work out so well. So what he did in 1965, he took 4 Navy medical corpsmen who were retired. He modeled the program on a fast-track medical school curriculum that, in fact, had been created at Emory University during the Second World War. 2 years of intense medical school-like training. The graduates were awarded a certificate of PA studies. The nursing piece came out of the University of Colorado. Loretta Ford and Henry Silver showed here. They had a pediatric nurse practitioner program. Their idea was to train public health nurses who already had a BSN to provide clinical services to underserved children. This was a very brief certificate program because these nurses had extensive bedside experience. It was 4 months long. By the early 1990s, APPs were being incorporated into some ICUs. This was a novel report in 1991 that concluded that with 3 months of training and looking at for the next 2 years, we conclude that properly trained PAs may have a role in providing health care in intensive care settings. They thought they were the first. They were not. What followed was a letter authored by Rob Grabencourt, a co-author on my presentation here today, back in January of 1992, where he said, you know, we have employed PAs in our postoperative CTICU for 12 years, going back now to 1980. Yeah, it happened at Emory first. Now, in 2008, SCCM President Ruth Kleinpel plenary speaker from yesterday, Wes Ely, and Rob Grabencourt published a paper. And they said in 2008, this is what we think the PA and NP workforce in the United States is going to look like. They were close. This is what it actually looks like today. The data are from the AANP and the NCCPA. The APP workforce has grown dramatically. In fact, if you look at the estimated numbers of APPs in critical care in the middle of the current decade, we think there are about 2,600 PAs doing critical care. We think there are about 7,100 nurse practitioners doing critical care. Rule of thumb, round number to have in your brain, about 10,000 advanced practice providers currently delivering critical care in these United States. Now, I know what you're thinking. How many practicing intensivists are there? Remember this picture that I showed you a couple of minutes ago from Derek Angus's paper? It's a bit of a moving target, and the reason it's a moving target is we have training programs putting people in, we have people retiring. We don't really know the number of practicing intensivists. That's at the bottom of the Star Trek symbol. All we can tell is the number of certified physicians. And in the most recent figures I could come up with, the American Board of Medical Specialties says that as of today, there are about 15,000 physicians who could be practicing critical care, but the number is clearly smaller because many of those who hold the certificate aren't actually at the bedside. So it's reasonable to conclude with the rate of growth of the APP critical care workforce, it's at and probably starting to eclipse the physician workforce. The outcomes matter. There have been many studies published. This one is coming up in our journal in 2017. They all say the same thing. NPs and other advanced practice providers provide high quality and cost-effective care through and comparing additional variables, now including discharge length of stay, readmission rates, charges. Everything says that APPs do a brilliant job providing care at the bedside. So a few take-home points as we go to the next section of the talk. APPs have been a rapidly expanding workforce. Their outcomes are indistinguishable from resident-staffed ICUs. The attending supervision has been similar. Demand has been rising, and the available physician supply is just starting to change. More on that towards the end. Anyway, I left Hopkins, went down to WashU, and what happened there is I encountered a brilliant colleague, Walt Boyle. Together, we directed a 24-bed surgery burn trauma ICU, and I want to walk you through this figure because it's a little hard to comprehend without some explanation. In the back row, the total number of house officers that we had, 2001 to 2009. Just in front of that is a purple row. Those were the R3s, the senior resident. They vanished. They were replaced in the red row. Those were interns coming in. So basically, we had progressively less experienced people at the bedside at all hours of the night. At the same time, in this period, fellowships in the United States were going unfilled. On the left, anesthesia critical care fellowships through 2005, 6, and 7, half were going unfilled. Second from the right, surgical critical care, a quarter of the fellowships were going unfilled. Nobody was going into the discipline. So we said, you know, maybe we needed to become an early adopter of APPs in the WashU SICU. Walt Boyle, our resident, then fellow, then associate director, and then the man who succeeded me as director of the WashU 84 ICU, past President Craig Coopersmith, said, why don't we try to persuade the hospital administration to hire a nurse practitioner? We did so in 2000. Beth Bayette joined the group, and here was the trajectory of growth of APPs in the WashU ICU. We hired Beth, we hired Kathy, we hired Ann, and then at the little red bar, I left, and Walt started hiring up. As of today, there are 35 APPs in their group. I moved down to Emory with Craig, and before I get to the details of what we did, just a little sidebar. In the United States, 55% of our health system costs are labor. In the ICU, the fraction of the cost devoted to labor is probably higher because we have more caregivers than patients. And the strategy that's evolved in the United States to wring value out of all of this is to have people working to the top of the license. It's a common strategy to hold labor costs in check. Our APPs make money. We have to provide financial support to pay for the attendings. And that explains why Vish and Sarah and Craig have embarked on this program to rapidly grow the APP workforce. At Emory's Critical Care Center, we have more than 100 advanced practice providers delivering critical care 24/7. I want to shift gears for a moment to something completely different and talk about Telemed. I attended this New York World's Fair in 1964. This was the Bell Picture phone. A coast-to-coast call in current dollars for 3 minutes would cost $270. Not viable. But people saw this and said, you know, maybe we can use this as a strategy to deliver remote critical care. It started in Cleveland with this hospital, the Forest City Hospital. Betty Grundy, an anesthesiologist, did an experiment in healthcare delivery and proved that telemedicine can enable an intensivist to consult with patients of a small hospital with no critical care physician of its own. It was pretty primitive. You see the massive types of cameras that they had there in those days, the monitoring station, these huge stacks that used to exist, but it worked. It worked so well that Mike Breslow and our fellow Brian Rosenfeld said, this is probably the way care is going to be delivered in the future. This report published in Forbes in 2002 talked about their initial operationalization of the concept. They basically said bye to Hopkins and left to set up a company devoted to remote critical care. And adoption of telemedicine in the United States took off. This is from Jeremy Kahn's paper. I'm showing you the data as they published it in 2014 in our journal. You can see at the top the hospital percentage adoption, the number of ICU beds in the United States, but look at the map. Look at how it is taking off. Now, there was some concern that it had reached some kind of plateau. Let me show you what's happened since 2009, 2010. These are the EICU programs, not just in the United States, but you'll notice around the world. There's an EICU program now in London. There's one just being launched in Tokyo. This is what the growth looks like in the United States. I've shown you the graphs from that previous article, and where you see the red squares, that's the beginning and end of the graph on the left. There was a little bit of a plateau, probably due to the economic crisis in the United States. Growth has continued monotonically upward. Telemedicine is at more than 15% of the ICU beds in the United States as of today, and there's no sign that it's slowing down. So what does EICU do and how does it work? This is a picture from our core at our clinical operations room in Atlanta. You have doctors, you have nurses, you have remote caregivers, and I want to show you a typical thing that happens many times a night in our ICU. You see in the graphs there the heart rate, the blood pressure, the oxygen saturation, the respiratory rate as a patient had just come back from a study or from the operating room. Clearly on the vent, the respiratory rate is flat as a pancake. And you'll notice that something happens about here. The heart rate had come down, the blood pressure had come up. The patient looked like she was doing well, but then there was a little dip in the oxygen saturation and the respiratory rate. That triggered an alarm. We called into the room, saw that there was a bit of a ventilator malfunction, said, you know, take the patient off the vent, bag the patient, figure out what's going on with the ventilator. Yeah, the patient had a transient desaturation down to 80. But the patient didn't arrest. Just one of those little things that we pick up to prevent bad outcomes. In fact, what happens in the EICU is that we're detecting and correcting anomalies. We detect an anomaly, we track it, we classify it, we project into the future, and then we decide if something needs to be done. If something needs to be done, we assign a task, and action is taken, and there's an evaluation. Does telemedicine work? The benefits are debated. This is a meta-analysis from 2012, and here are the data. If you look at the ICU mortality and the hospital mortality across a large number of studies, look at the black diamonds at the bottom, the outcomes favor telemedicine. The issues become what happens when you look more deeply. These are data from Craig Lilly that I'm about to show you, his JAMA paper published in 2011. If you look in the red box, it's pretty clear. The mortality rate drops to 0.4 of what the expected value is. The lengths of stay, you'd end up taking several days off the expected term in the ICU. Now, the costs are hotly debated. This is a paper published a couple of years ago in Chest, and basically it said all these initial studies suggested combined implementation and first-year operation costs for tele-ICU was between $50,000 and $100,000 per bed. And then the changes in patient care costs after implementation, there might be a reduction, but some people saw an increase in hospital costs. Is it worth it? Well, if we look at contemporary economic modeling, this was published in our journal early in 2016, the U paper, what you find is the following. If you can keep your cost per patient down to $577, you're already at break even. Now, our current costs are $643 per patient, but that doesn't even account for downstream savings. We'll talk about the downstream savings in a moment. In current dollars, if you can manage your way down to under $577 per patient, you're already ahead of the game. It takes time to accumulate those benefits. Another Craig Lilly paper that's just been published in Chest. You can see the data here. It takes time to move the case volumes up, the lengths of stay down. But eventually, yeah, you do save considerable amounts of money. We were fortunate to receive an innovation award from CMS. We applied in 2011. The award was made in 2012 to basically merge two innovations, to get NPs and PAs trained up in critical care and to support them with tele-ICU. We took two innovations, integrated them, and developed a novel care delivery model. Our training erases the barriers between our physicians, nurses, and APPs. They serve as a very flat team. And we focused on the training by developing a competency-based critical care residency. It's a 9 to 12-month program. It includes simulations, classroom work, bedside care, standard care. The bottom center, you see one of our folks running a simulated code blindfolded to emphasize the importance of communication in code management. Heather Meissen and Rob Grabencourt have shepherded this thing through over the past 5 years or so. We've now graduated, I think, about 37 people. The map that I'm showing you here is the map that's in the paper when we had about 30 graduates. Most stayed in Georgia, but of those who wandered across the United States, we know that 3 of them, 10% of our graduates, had already started their own training programs. So the concept of specialty training in critical care for advanced practice providers is taking off in the U.S. This is our current core in Dunwoody, Georgia. Cheryl Hiddleston operates this. We use the industry convergent EICU platform. Since March of 2013, we've cared for 22,000 unique patients over more than 82,000 patient days. Let me tell you what happens when you launch this type of model. The blue line that's horizontal is an observed to expected ratio of 1. I'm showing you ICU mortality ratios in one of our community hospitals. When we introduced our nurses, just the nurses, in September of 2013, the mortality rate plummeted. Having the electronic tools and nurses serving as sentries, evaluating the alerts and saying, you might want to take a look at that patient, mortality fell by about 2/3. The physicians, they didn't do much for mortality, but what they did do and continue to do is make care more efficient and effective. Care doesn't stop at 3 o'clock in the morning simply because the attending isn't there. The APPs who are here in the audience know when they push the button, they get me at 3 a.m. We estimate that we've saved close to 1,000 lives in the interval since June of 2014. That's about 30 months, 1,000 lives. We estimate that we've saved over 20,000 ICU days in that same 30-month interval. That's real outcome value. How about cost? Remember I mentioned that we got this grant from the federal government? It came with a string attached. Remember the ABT folks who did that compact study? The federal government went to ABT and said, you guys are going to keep an eye on what Emory's doing. Emory had no role in the evaluation other than to say, here, come on, look at what we're doing. ABT decided their metric would be the total cost of federal beneficiaries for the hospitalizations and extending 60 days post-discharge. In other words, they didn't want us hiding the costs in the ICU only to pick them up later. They chose the regional comparators based on their criteria, not ours. The data that I can share with you today was released last March. The initial estimate that every time we touched one of those 20,000 patients, we saved between $1,200 and $2,200, primarily because the patients were being discharged in better health with lower needs for long-term rehab and care. There has been further analysis completed. There's an abstract that's been submitted. The manuscript, since I've made this slide, the manuscript is in press. I cannot share those data with you because they are embargoed, but the new data will appear at the CMS site sometime in March, and let me simply say that the CMS folks are smiling broadly. So how short of intensivists are we in the United States? Well, the most recent Leapfrog survey says, yeah, we're short. It's a mosaic. If you want an intensivist, you should go to Washington State, Minnesota, Idaho, or Arizona. Georgia, not so much. This has created some controversy. There's been an exchange in one of our sister journals, in HARCCM. Jeremy Kahn wrote, ICUs are full of patients who don't need to be here. Let's slow the training down. Let's think about alternative workforces. This got a response from Steve Pastoris, John Orapello, and Vlad Kvetin. Said, look, folks, the current supply is low and people are leaving the field. Too much burnout. And then we get alternative views. This from Arizona and Yale. Tough choices ahead. We need to think out of the box. Regionalization, telemedicine, and avoid the ICU altogether. So how short are we of intensivists in the United States? These are data from the last decade's worth of training. Look only at the dark black line and the scale on the right. 2006, 2007, we produced 831 people with boards in critical care. Most recent year, a decade later, 1,300. The physician supply is starting to catch up. So I'm going to leave with a few closing thoughts. There are a couple of developing manpower pools. There are evolving technology. People and technology are answers, but they don't get to the core question. The question is, what are the tasks of critical care? How do we choose to allocate those tasks among people at the bedside and remotely, among nurses, APPs, and physicians? And how do we judge the performance and outcome of those allocations and assignments? Well, we are changing the way we allocate tasks. This is a figure from our Smarter ICU. Down in the lower left, you can see our team theater where we're doing rounds electronically, locally. Up in the upper right, you see our remote ICU. We started to ask, how remote can it be? We've just completed a 6-month project where we said we can do remote halfway around the world, 15,000 kilometers away. Why would we do that? Because I'm fresher at 3 in the afternoon than I am at 3 o'clock in the morning. We wanted to turn night into day. And in a partnership with Macquarie University in Sydney, we have done just that. Why is this important? Everyone knows about the action needed on burnout. We took 3 critical care nurses, 4 physicians, 6 to 9 week rotations. We covered the night shift mostly from daylight, 9, 10, and 11, A to P. The first nurse said, "This is the experience of a lifetime. Can I stay?" We had to pry his fingers loose from Sydney. And in fact, all 7 travelers said, "Can I go back? I want to do this again." We set it up as a 6-month research project, but in fact, we're designing Australia 2.0. And if you're at all interested in joining the team, come find me or one of my group hereafter. Let's chat, or just send me an email. My email address is up there, tbuchman@emory.ecu. There's no N in the address. Let me finish up. Everybody who's listened to me before knows that I have to talk about airplanes. This is what the panel of the airplane looked like when I started flying, about the time when I was an intern. I've been flying for 15 years before that, but this is during my residency at Hopkins. This is what a new panel looks like today. There's been a lot of advance. Those advances actually make a difference. And let me synchronize some of the most recent advances to our work in this project. 622 Hotel Juliet we acquired in 2011. It was a new generation airplane, new tools and new opportunities, just as we were setting up the EICU program. The airplane got re-engineered for safety. We acquired 6 Bravo Zulu at the same time. We were learning how to train and use APPs and remote critical care. We're just beginning to scratch the surface. What you're going to see over the next few years with APPs and remote critical care and the airplane is advancing performance, more power, more computing to enable better decisions. And as a reminder to myself to mention it, lower left, precision diagnosis is a team sport. We're going to have to expand the ICU caregiver team to all sorts of disciplines, pathologists, clinical pathologists, data scientists who've never been part of our team before, but they're going to help us take better care. And we're going to have to engage with other agencies such as the United States government and presidential initiatives. You heard Dr. Kleinpelt talk about the opportunities around supercomputing. That's going to be part of this program as well. What happened with the airplane? With better training, standard flying, and improving technology, meaningful improvements and outcomes that matter. We cut the death rate in this particular airplane from 1.8 per 100,000 flight hours to 0.6 per 100,000 flight hours over 6 years. A 2/3 reduction in mortality. We have to do that as well in critical care. We must do the same for our ICUs, our patients, their families, and ourselves. Let me close by saying thanks to the Society of Critical Care Medicine, to my entire critical care team family at Emory University, and also to my wife, daughter, and Barbara Rachel, who make it all possible. Thank you very much.